Good evening, and welcome to the League of Women Voters of Ames and Story County Candidate Forum for the Mary Greeley Medical Center Board of Trustees. Thank you for coming this evening. For those of you who might not be familiar, the League is a nonpartisan political organization dedicated to encouraging citizens to be informed participants in their government on the local, state, and national levels. This forum is being recorded for upload to YouTube and the League of Women Voters of Ames and Story County Facebook page, and will be played and archived on community radio station KHOI FM 89.1 at a later date. Today is Thursday, October 23rd, 2025. I'm Ann Kinzel, co-president with Carolyn Klaus. Carolyn's around here somewhere, of the League, and I will moderate tonight's forum. Let's begin. All declared candidates for these offices have been invited to this forum, and all are present tonight. The candidates for the Mary Greeley Medical Center Board of Trustees are Paul Hudson, Mary Kitchell, and Beth Swenson. And I want to take the time to thank our timekeeper, Mary Sue Hartung, and our question runner, Mary Louise Burke, for their work tonight, and also Mary Sand, who takes care of all our forums, which this year has proven to be a considerable endeavor, if you've followed us at all. This evening will be divided into three sections. First, there will be the candidates' opening statements, 3 minutes. Then the candidates will take questions from you, the audience, and finally, closing statements from the candidates as time allows. As audience members, if you have a question to ask the candidates, please raise your hand, and our runner will bring you a card or collect a card from you. And if things look informal, we will also just take hands at the end. I have some questions, though, that have already been submitted. So, the mic will remain open for you. Now, with candidates, we'll begin with opening remarks from each of you. Please limit your remarks to 3 minutes. Watch the timekeeper, and she will hold up a card when you have 30 seconds left of your allotted time. We'll start with the introductory remarks by Paul, Beth, and Mary in that order. So thank you, candidates, for being here this evening. Thank you for running for public office. It's an important endeavor, and one that is certainly not always recognized for the sacrifice that entails for those who make that decision. So we'll start with you, Mr. Hudson.
Thank you. My story starts with a bit of hubris in the sense that I watched the notice that Miss Sarah Buck had retired. So I was so bold as to actually go to the president of the organization and suggest that I'd be a perfect candidate to replace Miss Buck. And then Mr. Dieter and Mr. McCuskey were kind enough to actually entertain me and understand a little bit about my story and inform me that it'd be a year and a half before there was an actual vote for an open position, which is now. But in the meanwhile, I was able to actually serve as a community member on the strategic planning effort, and then I shadowed the board for that period of time. My backstory starts in Ames. I came here in kindergarten and have stayed since then. When I was an undergrad, I took a CPR class, and then a CPR instructor class, then an EMT class, then the first paramedic class at Mary Greeley, and was hired during the class to serve as a paramedic. And there followed 20 years of service as a paramedic at what became Mobile Intensive Care Services as a paramedic supervisor and an educator in the paramedic program and some community programs. And I think pausing for a sec to say that became part of who I am. That I'll always be a clinician in that respect, and I'll always be somebody that has a background in education and enjoys that particular way of contributing to society. And Mary Greeley was very kind to me. I developed a specialty in pediatrics, and they sent me to Washington, D.C., and they sent me to Oregon, and I was able to share that, and that became foundational to the genesis of the Pediatric Advanced Life Support class that the Heart Association did. They did a pilot at the University of Iowa, and when that class became a reality, I became regional faculty and then national faculty for that class. And that's part of my continuing through line after no longer becoming a formal educator. I still teach advanced cardiac life support, pediatric advanced life support, and BLS CPR. Continues coming up on like 48 years now with that. Anyway, so My time at Mary Greeley was impactful. I got to help serve the public, and it's a hospital-based ambulance service, so I got to understand the workings of the hospital. There came an opportunity to actually leverage my role as an educator to become the director of education for a physician practice. A physician entrepreneur who had started a practice and needed somebody to help teach. So Dr. Mark Menadu came in. So with 30 seconds left, forwards to the fact that I served 20 years with Managed Healthcare Services as the Chief Operating Officer, which became STAT US Health Partners. We served small and rural hospitals. I was the Chief Operating Officer for that organization, participated nationally in operations and in something like the Baldrige program as well. I was a national Baldrige examiner, so I was very impressed when Mary Greeley became that.
Thank you, Mr. Hudson, and we'll go to Ms. Swenson now.
Hi, my name is Beth Swenson. Let's see where I even want to start. I've spent 40 years working in a medical laboratory, 28 of which were at Mary Greeley. While there, I served on numerous committees, United Way, and became chair of United Way, served on the Employee Action Committee, was chair of the Employee Action Committee, served on the search committee as an employee representative when we hired Jeff Stevenson. That's how I got to meet Cal Halliburton, one of the highlights of my life. And, let's see, I came to love Mary Greeley. It really meant a lot to me. I worked at the hospice house and the gardens while I was an employee there. So the hospice house means a lot to me. I feel all of you. I've been on the board for 8 years. I feel that part of my responsibility on the board is to be an employee representative, and I face almost all the decisions that the board makes. In my mind, I go, how will this affect the employees? Because they are valued and respected at Mary Greeley, and I want to make sure that they stay that way. I want to continue to work to ensure that Mary Greeley is a safe and high-quality place to receive care. I think it's very important that we have a great hospital in the community, and I feel that responsibility on my shoulders serving as a board member. I hope that you all will consider voting for me. I want to continue to make Mary Greeley a great place to receive care and a great place to work. Thank you.
Thank you, Ms. Swenson. Ms. Kitchell.
Yes, thank you, Beth. I've been a board member at Mary Greeley for the past 25 years. My engagement with healthcare began right out of college. I'd earned graduate degrees in psychology at the University of Iowa, and my first job was I was hired as a psychological consultant at the University Hospital's pediatric department, where I was involved in direct patient care, research, and teaching of medical students. During my time there, I grew to love healthcare, but I also fell in love with somebody who graduated from the University of Iowa College of Medicine and decided to move to Ames. His work, so I feel like I have a very unique perspective on physicians and on the challenges and lifestyle that they have and all the pressures that they're under. And I think our physicians are a valuable asset. We cannot do anything at the hospital without the pen of the physician. During my time here, because my husband was so overwhelmed with work, I only worked part-time, but I worked part-time as a consultant at the Ames Counseling and Psychological Consultants, and retired about 3 years ago. But mental health continues to be a very special concern for me. Also, I have volunteered extensively in the community in a variety of roles, whether it's the school district, United Way, the Volunteer Center of Story County. For Mary Greeley, I was president of the auxiliary, president of the foundation, raised funds for the hospital, and ultimately I was asked to fill a vacant position on the board when, unfortunately, one of the board members developed a very devastating illness. And I've really enjoyed my time there. During that time, I hope that my contributions have added to the wisdom of the board. I've been selected for 5 different committees by the American Hospitals Association, advising them on best practices and what healthcare needs and challenges are in the Midwest in a hospital of our size. Our hospital is a valued community asset, and we need to preserve it. I also devoted 16 years of my life as chief cook and bottle washer at the and director of the Ames Free Medical Clinic, and that informs a lot of my decisions about and advocacy for those whose access to medical care is restricted. Thank you.
Thank you, candidates, for your remarks. Now it's time for our audience participation.
Could the candidates please move their microphones closer to them?
Certainly.
Don't be afraid. Love them dearly.
Thank you, Cal. All right, do we have any questions from the audience? Well, hearing none, I'll start with the ones that I've received, and perhaps this will embolden you to participate this evening, because you're here, so we want you to be part of this. The first question is rather long, so I'll read it carefully. When nursing home residents are admitted to the hospital, there is a risk of returning to their facility with a pressure wound or sore. These wounds can take a long time to heal and can cause the person pain and suffering. Some can be so severe as to hasten death. This can happen no matter the hospital where they were treated, whether regional or small town, no matter the size of the hospital or its reputation. Are you satisfied with Mary Greeley's procedures for prevention of pressure wounds as well as compliance with these procedures? If not, what changes would you make? And you have 2 minutes to answer, and we will start with Ms. Kitchell.
I'm happy to take this one because I'm chair of the Quality and Safety Committee at Mary Greeley Medical Center and have been for quite a few years. This is a particular passion for us. We try to identify those conditions that will put people at risk for harm, and that is one of the areas that we specifically studied. It's something that, I am not an expert to know what the best wound care is, but we do have experts in our facilities that do that. But we start by, on admission, 2 nurses must inspect every patient fully to see if there are any, that they are arriving in good conditions, because if they come from another facility and already have pressure ulcers, we have to be able to note that and treat them. Then there are specific measures that are evidence-based, based on different nursing standards that are followed, and the patients that not only have pressure ulcers, but those who don't have them, but every patient is examined every couple of days to make sure that they're not developing them. And there are certain areas on the body that are more prone to pressure ulcers than others, and those areas are specifically looked at. And thank you. And this is something we measure, and every month we look at the number of pressure injuries, and we looked at what is being done about them. And I am confident that we are doing a very good job attending to pressure ulcers. We have a very low incidence, and there are actually, I think, 5 stages or 4 stages of pressure ulcer, and we have not developed a pressure injury that is serious for several years.
Thank you, Ms. Kitchell. Mr. Hudson.
I'll give the perspective of a caregiver and a patient advocate. My mom was in the hospital for a month, and the surveillance and technology and the teamwork that was involved in executing on what Mrs. Kitchell described as something that I witnessed. So that the bony prominences of the body are the ones that are most vulnerable to development of pressure ulcers in a person that is laying on their back and is not rotated or moved in a position to release that pressure is vulnerable to developing or exacerbating those injuries. So I saw what Ms. Kitchell described in admirable detail being practiced. The only thing I would add was the use of technology, the bed, the air, the rotation, the concept of somebody developing a surveillance system where on a periodic basis the skin was evaluated for development of those problems.
Thank you, Mr. Hudson. Ms. Swenson.
I'm going to echo most of what Mary said, that indeed, anytime a patient is admitted, 2 nurses examine their entire skin surface to look for any kind of pressure, and they get examined again every number of days. Even if it starts out as a tiny little red dot, we keep an eye on that to make sure it doesn't develop into an ulcer. The Safety and Quality Commission or committee that Mary is on really does a good job of examining and looking into more detail about those injuries if they do occur. But the outcome, the number of skin injuries that we have are also noted every board meeting. We have a chart that comes out that tells us how many bed sores are happening or decubitus, and we follow that closely. Like I said, we really want to be a quality hospital, and that's one of our quality measures. So we try to stay on top of any kind of bed sores. So.
Thank you, Ms. Swenson. Has anybody come up with a question in the interim? Yes, ma'am.
My husband has recently retired, and after he retired, he did extensive research. He's a retired professor. And in the process, reviewed all the insurance possibilities from his various former employers. And we went with the University of Illinois system insurance because that was the first employer. And they were available and covered more things in many, many places. It was Aetna. Now, recently, we have been told that you will no longer take Aetna insurance. And I'm curious as to what research you did and why that decision was made.
Okay, we'll start with Mr. Hudson.
And
Yes.
how did your report read?
Sure. I think the question is, this woman has learned that Mary Greeley is no longer, or will no longer be taking Aetna insurance as an insurer for patients, and she would like to know if that is the case and why.
I have one more thing to add.
Please.
I did ask about the research, but when Iowa Heart announced that they weren't going to take Aetna insurance any longer, Mercy as a whole did research and made a decision that Aetna would be a fine insurance company. And I don't know what kind of research they did, but you might ask them.
The addition is that the Iowa Heart Center had also considered dropping Aetna and did some work and decided not to go in that direction. So I'll start with Mr. Hudson, followed by Ms. Swenson, and the last, Ms. Kitchell.
I can't speak authoritatively to this, but I'm going to make an inquiry. Are you talking about Aetna Insurance or Aetna Medicare Advantage?
Aetna Medicare Advantage.
So Medicare Advantage is a separate type of insurance, and there is a controversy nationwide in terms of reimbursement from a particular type of payer where Medicare Advantage is marketed extensively and is thought of it to be an excellent deal for Medicare recipients. There has come a calling whereby it seems that that product is disadvantageous to healthcare systems and possibly disadvantageous to a portion of the people that are enrolled in that. So I can't speak to the decision that Mary Greeley made, but I can tell you that it comports with what I've seen nationally and the advocacy that I've seen on behalf of small and rural hospitals to actually move people away from such products with the notion that it was disadvantageous to the survival of the hospital.
Thank you. Ms. Swenson?
I agree with what Paul said. It's Medicare Advantage of Aetna that we are no longer taking, and it's because they have such a poor reimbursement rate, and they're slow, very, very slow in their reimbursement. It takes a lot of time to get them to respond to claims and that sort of thing, and it just was more a problem than it was a solution, not only for the hospital but for the patient. They oftentimes had trouble getting pre-approval for procedures and that kind of thing, so.
I never had any
Haven't you?
experience with that.
Good, you're glad.
Yeah, thank you. Ms. Kitchell.
Yeah, the only thing I have to add, and this is probably a more technical issue related to our finance department, but it's my understanding, and again, it's the Medicare Advantage product, that it's not really an issue for the person who owns the policy, who is the patient. It is an issue for hospitals. It's been our experience, as I understand it, that it takes an inordinate amount of time processing claims. So you're seen at the hospital, and then the hospital issues a bill to your insurance company, and they then proceed to pay it. It requires an exhaustive prior approval process that we have nurses that spend entire days trying to get prior approval for insurance. And even when it's been approved prior to the encounter, often there will be a lengthy delay. I've heard as much as a year to process the claim. And even when they do process the claim and then they deny it, they may deny it even after a year. And that compared to other Medicare Advantage plans and just plain Medicare, they pay about 67% to 70% of the rate that Medicare pays to hospitals, which is why and Medicare is a low reimbursement. So Medicare is really, is a blow, and as Paul said, specifically to small rural hospitals, that it really makes a huge difference.
Thank you. Any other questions? Hearing none, I'll proceed with the next one here. What should be the board's process for maintaining standards of care when facing financial challenges? And we'll start with Ms. Kitchell.
Okay. I think every hospital in the country, or most of them anyway, are faced with financial challenges. As a board, we decided many years ago that our North Star, our guiding principle, would be quality and patient safety, that takes precedence over finances. Whenever there's a question of what do, we always adhere to the highest standards of care and then deal with the financial consequences. We do that by consistently mandating best practices for every care of the patient, following approved processes for the best type of care, and we monitor the outcomes to make sure that the outcomes are what they're supposed to be. We follow that no matter what the type of reimbursement or whether there's no reimbursement. All patients are treated the same, and most of our providers, our nurses, our doctors don't even know what the pay status of any of our patients are. So that's just our practice. Quality and safety are our North Star.
Thank you. Mr. Hudson.
I'll start with something that's going to sound a little strange, and that's no money, no mission. And so the idea is that the financial welfare of the organization actually supports the clinical mission. So the efficiency, effectiveness, process improvement are essential to being able to deliver the care. I agree that the guiding principles of the hospital is to take care of everybody regardless of their ability to pay to the best of the ability. But at the same time, it's essential that the financial stewardship of the hospital actually supports the sustainability of the enterprise. And under current duress, that really this is one of the issues that faces the hospital, is that with the shortfall in funds, what is going to be the way to gain efficiency, to institute growth, to be able to actually generate the revenue necessary to support the clinical care that is at an excellent level and needs to continue to be so.
Thank you. Ms. Swenson?
That's an interesting question, especially at this time, because Congress is kind of at a standstill as to what is going to happen in the next few years as far as Medicare and Medicaid reimbursement. So it's something that everybody has to look at. Mary's right, quality and safety are our North Star, and we will stay with that. Whatever we have to do, we want to have a good quality and safe product at the end. our product, of course, being healthcare. But it is our North Star, and we'll stay true to it. Somehow we'll come through. It all kind of depends on Congress right now, actually, and what they decide to do. So we're kind of at a standstill right now as far as our financial future. We have a financial future, and we will continue to be the institution that we are. We just don't know what's going to happen. If they make the cuts that they're talking about making, we'll have to face that when it comes down the pike. But we will not give up quality. We will not give up safety. And you can take my word on that.
Thank you. Our next question is, does the new Ames Surgery Center have a positive or negative financial impact on Mary Greeley Medical Center? Please explain your response. And we'll start with Mr. Hudson.
It's negative. So not to be short about it, but that ultimately what happened then is a transfer of well-paying procedures and surgeries to the outpatient environment. The hospital has a partial ownership in that, but there's a net deficit in terms of the movement of patients from one to the other. To say otherwise is sugarcoating it. And really what we need to do is, as a community, as a hospital specifically, is backfill into that hole to encourage or to sustain the hospital by virtue of coming up with new programs, increased efficiency, and then making up the deficit that's associated with the movement of those procedures and those surgeries to the surgery center.
Thank you. Ms. Kitchell?
Yeah, I agree with what Mr. Hudson said. I think that we had to support the opening of the surgery center for a variety of reasons. One reason is this is something the physicians really wanted. This is something, their incomes over time have deteriorated, despite the fact that they have years and years of training. They've only received, I think, about a 3% raise in the past 24 years from Medicaid. So they're actually, compared to everybody else that's getting cost of living raises, they have to find other ways of gaining income. We decided to go into partnership with the physician group because half of something is better than none of something. So we felt it was to our advantage to retain the talent that we are blessed with having, and help surgeons add to their income, and we'll still reap some of the benefits of losing about $20 to $30 million worth of income that we gain from the surgeries, having the surgeries within the hospital. It's not been in operation long enough to really determine exactly how it's doing. As far as I know, even though it's been open for just a brief period of time, it's breaking even.
Thank you. Ms. Swenson?
The surgical center, let's face it, it's expensive to have surgery in a hospital. It is. You have to pay for a facility that's open 24 hours a day, 7 days a week. Overhead is expensive. So to have surgery in a hospital is an expensive proposition. The insurance companies were saying, well, if there's a standalone surgical center within 50 miles of you, we'll pay for you to have surgery there, but we won't pay for it if you have it in the hospital, as long as it's an outpatient surgery. And so that was one of the factors that helped us with starting a surgical center. One of the big factors. We wanted to have it in our community, and we wanted to have a say in how it was run, rather than to have an outside hospital come in and set up a surgical center. We would rather have our own. And is another reason that we started looking at having a surgical center. And like Mary said, the physicians are ready for it. So there were a number of reasons that we did it. Yes, we have lost some income. And yes, we are looking for ways to backfill that income. We're exploring a number of different possibilities. We've not settled on one yet, but we continue to look. So we will make up that shortfall. And when we do, it will be quality and safe. Thank you.
Thank you. Our next question, first I'll check again. Any questions from the audience? No? Okay, hearing none. What effects do you see in reductions of Medicaid reimbursement on Mary Greeley Medical Center? And we'll start with Ms. Kitchell.
Okay, well, we don't yet know what's going to happen with Medicaid. When the Affordable Care Act was being developed, I served on national advocacy panels that really lobbied for an expansion of Medicaid. Most of our clients at the free clinic immediately became eligible for Medicaid. I know there's a lot of argument that, oh, these people that are on Medicaid are just freeloaders, they just don't want to work. That's not true. The clients at the free clinic were people that served small businesses in the community. They're the cooks, the dishwashers, the hotel cleaners. These are all people that are hardworking and did not have access to insurance beforehand. Once Iowa decided to adopt Medicaid, it brought a whole new level of dignity to my former clients at the free clinic, which I was happy to see. That may go away. I think the impact for individuals is going to be profound. I'm more worried about them than I am about the hospital, because we survived before they had Medicaid. We'll survive after it goes away, if it does. I hope it doesn't. I'll be very upset about it.
Thank you. Mr. Hudson.
I think part of what we need to do is forecast. So what the Medicaid percentage of reimbursement of the hospital has to be forecast, and then a supposition is that the work requirement that's associated with Medicaid is also going to affect the eligibility of people that would otherwise be eligible for Medicaid. So we start with the notion that the work requirement affects the people that are in Medicaid, and then maintaining the population that is eligible for Medicaid is going to be essential. So you start with that, is there going to be an effect? And then to figure out how that affects the payer mix, because the supposition is that people that are off Medicaid will go into what's called self-pay. And that is a different population and a different challenge for the hospital. And the hospital has to decide, under circumstances whereby there is no insurance, whether it be a commercial payer or a federal payer, then how does one actually approach or discount the amounts of pay cost associated with somebody that doesn't have those insurance? So I guess I'd offer the fact that is the work requirement going to affect the people? Do we have operational plans to make sure that people that are eligible still maintain their eligibility, so we maintain the greatest percentage of people that are enrolled in Medicaid, and then after that to actually develop a system that is equitable and fair to the people that don't have insurance but still have the ability to pay?
Thank you. Ms. Swenson.
Yeah, let's see. Medicare and Medicaid, what's going to happen to them is the big question right now. As Mary said, we will survive. We survived before we had Medicaid and Medicare, and, well, I don't know about Medicare, it was a long time ago, but yeah. I think we'll be okay. I really, really do think we'll be okay. And we will still treat people whether they're insured or not. That's part of who we are. I'm more worried about the smaller rural hospitals that can lose reimbursement, or their reimbursement rates will go down. I think a lot of them are already struggling, and I'm afraid that the financial hit that the smaller hospitals would take. I come from Mount Pleasant. We have a average inpatient volume of 2, and our hospital won't be able, in Mount Pleasant, won't be able to sustain that if there's a big cut to Medicare and Medicaid. They just won't. So consequently, if they close, where do those people go? And so if, I'm just going to pick on Boone because they're close. If they were to have to close because of their financial reimbursement from Medicare and Medicaid, where are those people going to go? They're going to come to Mary Greeley. So not only are they dealing with the financial loss of Medicare and Medicaid, they transfer it to us. So I think we're kind of in a quagmire right now, and it's kind of scary. But we're aware of it, and we can look forward to what we're going to do and how we're going to handle situations. And that, I think, gives us a leg up. So we're aware of what's going on, and we're planning for it. Thank you.
Thank you. The Village Voice, a new newslet outlet in Ames, published an article today intimating that a decision had been made to close the Israel Hospice House. Could you please state your position on that? And we will start with Ms. Kitchell.
Okay, well, they have not come to a final decision. I don't know if it's the final decision, but it is on the agenda for our board meeting next Tuesday. So there's not been a final decision. That was possibly a misquote from the press release. It's going to be a very, very tough decision because we understand how the hospice house has impacted the community. I was on the original committee that was involved in the design and the fundraising for the hospice house when it first opened. I spent a lot of time and effort expressing the advantages of having that to the community, and I've received lots of feedback that it's been a wonderful resource for families. The problem is that when it was originally projected, we knew because of Medicare reimbursement that it would lose money, but we raised an endowment also to supplement the losses that we would incur so that this house would be self-sustaining. Last year, the hospice house generated net operating loss of $1 million compared to $300,000. It's not sustainable to continue with that. In case anybody wants to come up and write me a check for $25 million so I can fund it for the next 10 years, I'd be welcome to accept all comers for that. So we're going to have to struggle with finding alternatives that will be successful, and it's going to be a very tough decision to make.
Thank you. Ms. Swenson.
Hospice care is becoming more and more home-centered, and people are choosing to stay home and have the hospice care come to them rather than going to an institution. And I think that plays largely into decisions that we have to make. Also, it's kind of prohibitive to have an in-house hospice care if you don't have a lot of money. And so we want to ensure that everybody has the opportunity to have hospice care through in-house, where you can have it in your home, or we're also making arrangements with hospitals with which we have a partnership agreement, and some nursing homes, so that if you do indeed have to have or in need of an inpatient hospice care, it'll be available to you. I love that building out there. I love those gardens. They're well in my heart, and I really feel badly about any decision that we have to make. But it's a tough decision, and we have to make it. That's whatever the decision is, we have to make it. So.
Thank you. Mr. Hudson.
And I think directly responsive to the question, I'm supportive of it, and that it sounds like, kicking a puppy. So, but I'll echo some of the things that have been said. One of the things, the perspective I've got, is it was noted in the article that there is a for-profit or private enterprise that supports hospice care. And I'm witnessing that at my mother's placement at Green Hills. So the part of being in the restorative care wing is the fact that there are members of this organization that serve the hospice population that are there. So I think that what Beth has said is true in the sense that there's been a migration to hospice at home, hospice in the nursing homes, and a movement away from some of the residential opportunities that people have. The other thing Ms. Kitchell said I think is important, and that's the idea that this is an unsustainable enterprise absent some sort of other funding. So while it is it's a sadness, and it's a place that I went as a paramedic to take care of people, that ultimately I think it's the wise decision for the hospital to proceed this way.
Thank you. Any other questions from the floor? Then I have one more question, and it's a known,
That's okay.
oh, I'm sorry.
That's all right. So I have one question that's probably outside of the purview of your powers, and that is that it seems to me that it's euphemistic to call the American healthcare system. System, to me, connotes organization. Seems to me this is a big kludge of workarounds. And I respect you guys for trying to even get through it. So it's not it's an observation. Does it seem that way to you too?
Ms. Kitchell?
Not quite sure what the question was.
I think the question
But
is,
is a
is
system,
our healthcare,
is it a
American
system?
health a system?
I would say not a single system. Everybody thinks they have a system, but there are multiple systems operating here. And if anybody was smart enough to figure out a way to somehow cause cohesion among these symptoms, nobody has figured that out yet. And we must, as a society, figure that out. I think healthcare is just way too expensive. It's too expensive for people receiving care. It's too expensive for people giving care. And it's expensive for our employers that are providing the funding, or the government that are providing care. We also already see fractures in the government about how to fund healthcare. And different interests are looking at different things, and it's somebody beyond my level of pay grade to figure out exactly what the system is. But I don't think there is a single system. I'm with you.
Ms. Swenson?
I agree. I don't think there is a single system at all. I think the only way to have a single system is to go with Medicare for all. And then it's government controlled, so whatever your opinion on that is, I'll leave that up to you. But as long as we're independently operated and have competition between facilities, competition between providers, competition between insurance, there's no control there. And I don't know how you would ever get control unless the government steps in and takes control. So, yeah, I think that's the only way we'll have a system.
Thank you. Mr. Hudson?
And it's broken, indisputably, and I think part of what we're aiming at is to try and decrease the inefficiency and overhead associated with care. So the commercial payer system is such that there are layers of people that have to handle the claim and process it, so those people all get paid. So the notion is that the generation of revenue by the hospital is dependent upon the provision of services and the coverage of overhead, and that has to run its way through different payers, governmental payers and commercial payers and the like, and all those have complexities. And they're trying to exert some sort of control in terms of, well, I'll pay for performance or I'll pay for outcomes. But thus far, it hasn't really borne fruit. So it seems like what's happening is the addition of new technologies and new opportunities adds costs, and people demand that cost, or they demand that care. But at the same time, it's difficult for us to pay for it, or alternatively restrict access to that care to a select few.
Thank you. One last question. It's common nationally now for physician practices to merge with others or to close and form other practices. Are you concerned about McFarland's continued operation as a care partner with the Mary Greeley Medical Center? And we'll start with Beth Swenson.
We have a really great relationship with McFarland Clinic, and we work in tandem essentially for providing care to the whole community. But also, you know, one great example is the surgical center. That was a partnership. We formed that partnership. It's 50-50. The physicians were very willing and gracious to go, not gracious, well, we were both gracious to start that endeavor. You know, it was give and take on both parts. You know, the hospital was used to running a hospital, and the clinic was used to running a clinic, and now all of a sudden we have to join forces to have a successful business. and it worked out well. I have no hesitation in giving my full support and appreciation and acknowledgement to McFarland Clinic because they do a really great job. They may grow, they may do more outreach, and I don't know what's going to happen in the future if we would consider partnering in doing some more outreach. I don't know. It's a possibility. Everything's up in the air, but I feel confident that McFarland will stay McFarland Clinic.
Thank you. Ms. Kitchell.
Yeah, as I said before, I think physicians are an asset. They're what make Mary Greeley great because we're unique for a hospital our size to have such a collection of not only primary care staff, but also a wide range of specialists that make that kind of specialty care available to a relatively small hospital in the community. One reason why we're able to attract such a excellent medical practice is that the physicians that come there enjoy the autonomy that they have and their ability to self-govern their practice without the imposition of hospital standards. And I think if we can preserve that, if we can find ways to make them successful, that is going to preserve McFarland and our ability to attract physicians who are interested in practicing high-quality members. I've been part of recruiting physicians, and they constantly express to me the high quality of care that we give, the ability to be self-governed, the ability to make their own decisions, not to be just fulfilling the decisions of a higher boss that's a hospital, and the ability to be autonomous. So we want to preserve that as much as we can.
Thank you. Mr. Hudson.
In answer to the question, I'm not particularly concerned. I don't have any insider knowledge, but I should imagine that McFarland over the years has been approached multiple times for some sort of acquisition, merger, and the like, and they've resisted that based upon their ability to actually have the practice that they desire and the governance that they desire and the relationship with the hospital that is able to accommodate their specialties. I wouldn't prefer it, that if there was a buyout, but if that was the case, I trust the governance of McFarland and the physicians involved that they would select an appropriate partner that would continue the standard of care that they provide presently.
Thank you, Mr. Hudson. Okay, we've reached the point of the evening where we're going to have closing remarks. Candidates, if you would like to respond further to any question that's been asked of you this evening or make any other final remarks, you have 2 minutes to do so. We will begin with Mary Kitchell, followed by Beth Swenson, and then Paul Hudson. Please begin.
Okay. As I said, I think our community is blessed with the asset that is Mary Greeley, and it's the express intent of the board to preserve that as an asset for our community. So we have to manage and make good decisions about management of our finances and also the provision of high quality care. I'm particularly, we have a lot of tough decisions to make in the days ahead, but most of our decisions are based on data, on what's going on objective information that we have. And we measure a lot of things and we compare a lot of things. But ultimately, I think our decisions, and I speak for myself, but I think this is true of the board, are based on the 4 principles of medical ethics. And that involves do no harm, beneficence, do good, autonomy, listening to the voice of the patient and allowing them to make decisions, and justice, equal care for all.
Thank you. Ms. Swenson.
Closing remarks. Well, let's see. I have enjoyed 8 years on the board. I've learned a lot. I would appreciate having more time on the board because I continue to learn. Every meeting I go, I learn something new. We do have a quality hospital. We keep track of all of our inadequacies, so to speak, and find ways to improve on everything we do every time we meet. I think that we are financially in a good place right now, and I want to make sure that we stay that way. I want to make sure that we continue to provide safe and quality care. I know that surprises you. And I want to ensure that our employees are valued and respected. As long as we have great employees, we'll have great patient care. They go hand in hand. And that's my goal to stay on the board, is to ensure that we have a strong hospital, that we have a quality hospital, and that we have a great place to work. Thank you.
Thank you. Mr. Hudson?
I'm a late in life learner. I went back to school relatively late for an MBA and then a master's in healthcare administration, and then transferred into a position of authority with the physician practice, and then visited hospitals for 21 years. And during that period of time was elected to the board of the Baldrige Award National Examiners. And we went through very difficult examinations of highly qualified, nationally known organizations that never made it to a visit. So I remember, with that background and the knowledge of what was going on, to actually learn that Mary Greeley achieved that award. And I went to Mr. Dieter and said, that's amazing. I mean, I've interviewed people at places that didn't, and I think that's emblematic of the notion of the foundational strength of the organization. And so in my observation over the last year as a patient advocate and as somebody that shadowed the board, I'm very, very impressed with the organization. And I'd be honored to have the opportunity to join in an advisory role of the board to support that organization.
Thank you. Well, I want to thank the candidates for a very informative evening. I want to thank all of you for doing your duty as citizens to be informed. And before we conclude, I want to remind everyone to vote on Tuesday, November 4th. If you're not already registered, you may do so on November 4th at your correct polling place for your address. For that, you must have proper ID. If you vote by mail, you have until Tuesday, November 4th at 5 p.m. to have your ballot inside the auditor's office in the administration building, 900 6th Street, Nevada. Ballots not delivered either by you or the U.S. Postal Service by 5 p.m. on Election Day will not be counted. There will be 2 satellite voting stations in Ames tomorrow, Friday, October 24th, at the new 60 Forward Center on South Walnut in Ames, and Saturday, November 1st at the Ames Public Library right here. Both events will be held between 9 and 4 p.m. Of course, you can also vote at the Story County Auditor's Office in Nevada during their working hours. And once again, I want to thank the candidates for taking the time to share your views and for your commitment to serve. And thank you for all of you here for actively participating in the election process. This concludes our candidate forum, and I want to thank our audiovisual specialist, Denny Goodrich, for all his work this evening. Good evening, folks. Enjoy the rest of the day.